Hi, I'm Tyson Parks. This is our CLC health assessment. I am going to be the patient in all these slides. I am a D1 baseball pitcher with a dislocated right shoulder. Garrett will be speaking on sample health risk assessment slides, and Madison will be speaking on the static posture analysis, and Mallory will be presenting the overhead squat assessment, and Haley will be presenting the range of motion assessment, and lastly, Kylie will be presenting on the strength assessment.
This is a sample health risk assessment for Kyson Parks, who's a Division I college baseball pitcher who recently suffered a right shoulder dislocation on January 5th, 2025. Kyson's injury involves hyper and hypomobility, leading to a significant pain and instability, with pain levels currently at about a 7 out of 10. He's experiencing limited range of motion due to some pain, particularly with internal and external rotation, along with extreme shoulder weakness, which affects his ability to perform key pitching motions. Right now, his treatment has included rest, ice, immobilization, and physical therapy, but the injury impact on his stability means that he cannot currently participate in pitching. His throwing load currently, which previously has included about 95 to 120 pitches per game, with recovery of about 4 days, must be reassessed, and a focus on recovery is absolutely essential. In terms of risk factors, Kyson is at a high risk for further injury due to the history of shoulder dislocation overuse from throwing and poor scapular control. Moving forward, recommendations include rest, rotator cuff strengthening, scapular stabilization, and targeting flexibility work as well. Most importantly, Kyson should avoid any high-risk pitching motions like heavy curve balls until further evaluation can be taken. Kyson's acknowledgement of this plan is crucial for his rehabilitation and long-term health, and we will continue to monitor his progress and ensure the best outcome.
All right, so I'm Madison, and I'm doing the static posture analysis. So as you can see, I drew a line down the midline of Kyson, and I based all of my posture assessments based off of what is seen as normal and what is seen as malaligned. So first of all, you can see there's an obvious shoulder malalignment. The right shoulder is dropping down lower than the left. This is probably due to his shoulder dislocation, which is causing his muscles around his right shoulder to be weakened and not letting him keep his right shoulder up in the correct posture. So it looks like a scapular depression from instability. And then for the head position, you can see his head is tilting off to the left a little bit. There's a slight head tilt, which can be from, once again, the inadequate musculature around the neck. And then as far as the lower half goes, there's not really any valgus or varus seen with the knees, and there's maybe some slight foot pronation, but nothing too crazy. Now onto the posterior view. You can see once again the right shoulder is dropping down. This is probably from the weakened rhomboids, lower trapezius, or the serratus anterior, which can contribute to that. And then there's a slight hip hike, so the left hip looks a little bit higher than the right hip. Due to research shows that pitchers can commonly develop lots of injuries from repetitive motion, since they're constantly pitching with the same arm and rotating in the same direction. So this hip hike could be caused by that. And then there's the spinal alignment looks pretty good. No scoliosis is seen. A more thorough assessment would need to be seen or evaluated to see if there's any scoliosis, like with a shirt off or something, but from this photo, nothing can be seen. And then for the lateral view, it looks like he has a bit of upper cross syndrome, which usually is characterized by forward head and rounded shoulders. This can cause like postural imbalances, and shoulder injuries can also contribute to this, since the muscles are weak, so it's harder for patients to stand upright. And then the shoulders, once again, are pronated, so this can show tightness from the chest muscles like the pectoralis major and minor, and weakness in the posterior rotator cuff. There looks like there's a slight lean forward, so his weight is more on his toes than his heels, which can also contribute to upper cross syndrome. And then it doesn't seem like there's any anterior or posterior pelvic tilt.
All right, so based on the static posture, we decided to do an overhead squat assessment in order to test transitional movement. This is our anterior view, and we could see based on the lines that his foot and ankle they have an uneven start position, which alters the knee alignment. So when we go down to the knee, it appears uneven due to the staggered start. For the lumbopelvic hip complex, it appears normal from this angle, but we'll look at the other angles as well. For the shoulder, there's obvious lack of use in one shoulder due to the injury. He decided he didn't want to deal with the pain, so we didn't assess that in this. As far as the head and cervical spine goes, it appears normal from this angle, and as far as other notes, the client expressed discomfort, so they're unable to assume a normal start position with the arms both raised overhead, and not much depth is achieved in the squat. From the posterior view, when we assess the foot and ankle, we could see from this angle that the feet appear to have achieved a better start position, and the heels are flat on the ground at the bottom of the movement, which is normal. That's what we're looking for. As far as the knees, they appear to be aligned from this angle. For the lumbopelvic hip complex, the hips appear level with no asymmetrical weight shift despite the shoulder imbalances. For the shoulder, there's still the obvious shift due to one arm being excluded. For the head and cervical spine, they appear to be in alignment with the thoracic and lumbar spine, as well as creating an aligned spinal column. For other notes, despite errors seen in the previously mentioned slide, they're not as noticeable from this angle besides the shoulder malalignment. For the lateral view, ankle dorsiflexion appears adequate and the foot remains relatively flat with a slight lifting of the heel at the bottom of the movement. The knees appear in alignment throughout the duration. For the lumbopelvic hip complex, there's no excessive lumbar kyphosis, and there's a normal appearance despite inadequate squat depth. For shoulders, the arms fall forward for balance, not reaching proper overhead position, which is to be expected with the injury. For the head and cervical spine, it appears to remain in alignment from this angle, and for other notes, this angle highlights good posture, but it also highlights a lack of a posture. Sorry. It won't go back, due to the shoulder malalignment.
For the range of motion, we tested on his injured, which is his right shoulder. We did the flexion, extension, internal, external, rotation, and the abduction. The normal measurements for the shoulder movements were flexion for 180, which he measured at 110 degree. The extension for a normal person would be 45 to 60. He then measured a 35 degree extension. Internal rotation for a normal would be 70 to 90 degrees. He measured a 60, and the external rotation for a 90 degrees, but he measured a 62. The abduction was decreased from 150 for a normal range to a 115. These differences, or the decreased range of motion, can be caused by the weak rotator cuff muscles and also the instability and pain that he is feeling within his shoulder.
Hi, I'm Kylie and I did the strength assessment of the shoulder. So for this, we did the shoulder external rotator assessment, which has the joint position that's tested as the shoulder internal rotation. The muscles assessed are going to be the subscapularis, teres major, anterior deltoid, latissimus dorsi, and pectoralis major. We did this on both shoulders for each of the tests. And for all of them, on his right shoulder, his dislocated shoulder, he scored a 1. He was unable to withstand any of the pressure that was applied. For his left shoulder, he scored a 3, which means he was able to withstand pressure that I applied to his shoulder. For the shoulder internal rotators, the joint position tested is the scapular adduction and downward rotation. The muscles assessed were the rhomboids, middle trapezius, upper trapezius, levator scapulae. And there's also, as I said, he scored a 1 on his injured shoulder. For the lower trapezius assessment, the joint position tested was the scapular upward rotation and abduction. And the muscles assessed for this was the serratus anterior. To accomplish the testing for the shoulder external rotators assessment, ideally the patient would be sitting, holding their arm at a 90 degree angle with their arm to their side. You would ideally support the opposite shoulder so they didn't compensate in any way, and apply pressure towards the outside of their arm in an inwards direction, having the patient try and hold the resistance by pushing out. If they were able to withstand it, a 3 with compensation would be a 2 and not a 1. For the shoulder internal rotators assessment, it would be very similar. The patient would be sitting down. You would put pressure on the inward of the wrist towards the outside, having them pull their shoulder in to test those muscles. And the lower trapezius assessment is ideally done laying down with the patient in a prone position, having the client extend their elbow and shoulder fully. Their shoulder should be around 145 degrees of abduction and external rotation. And as you place support on the opposing shoulder, again, to limit compensation, you would put pressure in a downward direction near their wrist and have them try and push up. And then these are our contributions and our references.